Welcome, Professor Sheila Martins, to this interview. We are very glad to receive you.
Thank you. It's a pleasure to be here with you, Rodrigo.
Professor Sheila, I want to start with a question. How has been the journey of developing the stroke care in Brazil?
Well, it was a challenge, but as we have a strong team here that started to organize the stroke services in local with individual efforts, and you had the opportunity to put together our experience from different parts of the country to show to the Ministry of Health that was feasible and decrease morbidity and mortality if you organize stroke care in the country. We had this opportunity in 2007 to show them what we are doing. And because of this, they invited me to be an advisor of the Ministry of Health to create and to start the implementation of a stroke program in Brazil. Because of this, we put together the experts that were working on this in Brazil and created the Brazilian Stroke Network as a non-governmental organization to work together with the Ministry of Health, but independently of political and other issues that could stop our project in Brazil. It was the suggestion of Vladimir Hashinsky that believed that we need to work independently of the government or politician reasons that could interrupt the project. And it was very important because in middle of the development, really they changed the government and changed the minds and tried to stop the program. And as we had the Brazilian Stroke Network, we continued the development without the Ministry of Health for a time in 2009, 2010. And so for this, I think it's very important to create a formal organization to work independent of politicians. But it's very important to work with them to ensure continuity. For this, we start the organization, we create a plan, we start to evaluate the situation in the country. I personally travel to the whole country to see the situation and to meet the health managers in local and to evaluate the hospitals, creating plans tailoring to each resource and personnel in each part of the country. And with this, because of this good experience in pilot project created in different parts of the country, in 2012, we had the publication of National Policy of Stroke by the Ministry of Health in Brazil, approving the thrombolysis for the public health system of care with payment from the government, and creating stroke services in different levels with better reimbursement for hospitals with stroke units and with payment to the whole stroke team inside the hospital. It was really a landmark for us in Brazil, because from there we developed a lot, not only the public hospitals, but also the private hospitals too, that come together with the movement to develop stroke systems of care in Brazil. Always is important to remember that for this national policy, the stroke center is the coordinator in the region, and the stroke center should develop the rest of the network, training the pre-hospital, training the other hospitals, educating the population about the stroke awareness, about the symptoms, and to go to a stroke center, calling the pre-hospital, and also talking about prevention to the population, and helping the education of primary care units to recognize stroke, and also for primary and secondary prevention. So really, we create a complete program in Brazil from the Ministry of Health, but also with a very important contribution of neurologists in the country.
That's very amazing, Sheila. That's incredible, the work that you have done. And you continue the work afterwards, not only, as you said, prevention and thrombolysis and medical management and ICUs. You also now continue with the resilient in order for going with the mechanical thrombectomy. What was that experience?
Well, it was great because we didn't have the evidence in the world about thrombectomy yet. When I convinced the Minister of Health that the next step would be test thrombectomy in public health system of Brazil. So they gave us money for the trial. They negotiate with the industry to donate the devices. So we have devices donated by Medtronic and Penumbra. We have donation from Rapid for perfusion for perfusion to evaluate if it was important also to select the patients. And with this, we had a clinical trial. We evaluate the whole country, the possibilities to implement advanced stroke care in the hospitals with a Anjo Suite, neurointerventionalist trained anesthesiologist, and the pathways to assist fast the patients for thrombectomy. We had a huge training for interventionalists to learn how to do thrombectomy because they didn't have experience in public hospitals in Brazil. And for the trial, we had to include 3 patients. Well, before this, most important, when we are preparing to start the trial, the international trials were approved in the world and thrombectomy was approved. So with this, we asked to the Ministry of Health to only run a registry in Brazil to show that was feasible, and they didn't allow us. They asked us for a clinical trial because we had a more vulnerable situation in Brazil. The public hospitals have no complete structure, only monoplane, angiography. The interventionalists without a huge training. So they didn't know if really we would have the same results of international trials. And for this, we had to run a clinical trial, and when the 5 clinical trials were already showed that the treatment was effective. So for this, we include 3 patients in each hospital to evaluate the skills for neurointerventionalists and pathways and the times in the metrics of the hospital to participate in the trial. If the results were good, we start the randomization. If the results were not good, Raul Nogueira and Francisco Montalverne, Daniel Abuti, Pedro Magalhães, call the interventionists, show what they did, and teach them how to do better. And after this, they should include 2 more patients, review again to be approved. We had some hospitals that should include 10 patients before to be approved, but it was very interesting learning curve, and we will present the results comparing the rolling phase and randomized patients from Brazilian trial, showing that really it was very important to train and to evaluate the skills before to approve the hospitals to randomize the patients, showing that really thrombectomy is very effective and cost effective, but need skills, need a huge training for the interventionalists to really make possible implementation and to have good outcomes. At the end of this study, we show that thrombectomy is effective and cost-effective in the scenario of public health system in a middle-income country. And we submit for incorporation in the Ministry of Health of Brazil, and they approved thrombectomy for the public health system in the country. And also, we show to the rest of the world that was feasible to implement thrombectomy in low and middle-income countries.
Oh, congratulations! Congratulations! Well, it's for us that we also live in a middle-income country. Also, it's an example of how to do it. Thank you for that. And how working from a developing country has been, as you think, has been an advantage or a barrier?
Well, depends for what. And I think here we have a lot of opportunities to develop good things to show to the world that is possible to implement. And I really believe that we can do a lot in our countries. And really believe that working together, we can show that really we can do wonderful things and implement the best treatments to all patients across the globe. So for this, I think to live in a developing country is very important to the World Stroke Organization, because we know the reality, we know the challenges, the gaps, and we learn how to really create creative solutions, innovative solutions to implement the treatments here.
You were talking also about how the importance of experience in the results of the resilient trial. So also the quality, I think it's important, and you are very involved in the certification of centers in South America and around the world. So can you tell us more about that?
Yes. Well, when we launch a program of stroke centers, some hospitals are doing very well and others are implementing half of things that are important for the patients. So because of this, I think the certification is important to have an external audit looking at the hospital, looking the process, the training of the team, the registries, and comparing the medical records of the quality indicators registry, and to teach them how to be better. Because if you cannot see what they are doing, we cannot prove that they really are doing this. Is the certification. We are going there, knowing the teams, testing them for the protocols, because if they are assisting stroke patients, they need to know the protocols. And evaluating the structure, the physical structure, evaluating the emergency room, the stroke unit, the angio suite, the devices available, and evaluating the pathway of the patient through the medical records, and comparing these medical records with the quality indicators registry to validate the quality indicators registry. And with this, we ensure the implementation of all evidence-based strategies that make difference to the patients. Because here in Brazil, the Ministry of Health is paying for this quality in the hospital, but if nobody goes there to see if they implement some parts of the country, they are receiving the money and they are doing nothing for the patient. So the idea is to really visit and see if everything is there. And we are seeing that the hospitals are improving to receive the certification. They are creating things that they didn't have before. For example, multidisciplinary rounds at least once a week, a stroke coordinator, a leader of the stroke unit, a person that will review the quality indicators and make action plans to change and to improve. So these are only organizational things that are not implemented, but they easily can do it. The other thing is training. We need to see the certificate of neurointerventionalist, the certification of training for NIH stroke scale, modifier ranking scale, training for acute stroke care. So really we are putting everybody in the same page for stroke care. And when we visit some hospitals, they have everything in place, but for neurointervention, sometimes they don't have yet the skills. How we are seeing this? Because of the outcomes, too bad outcomes. So what we are doing after the certification, they have everything in place, and we create a mechanical thrombectomy pathways that is a extra training for interventionalists, discussing difficult case, as we did in Brazil for resilient trial, discussing difficult case with experts that can give different opinion, and this external expert, will be available 24/7 during 1 week to go in any hospital, to go together to see in place the neurointerventionalist working and giving advice or discussing different possibilities for the treatment. The idea is always improve the quality. So we are doing this too.
And do you think that how do you see the next generations of future doctors are coming? Do you think that they are aiming to take care about stroke? They're willing to, they're pushing forward to against stroke?
Yes, I think we are creating in our residents a lot of good neurologists and interventionalists. And at least because stroke is too frequent, some ones want to be other specialties, but they know how to treat acute care. And this is very important because you need a lot of doctors trained. Really, I think to see the results and to see the possibilities to treat these patients has stimulated young neurologists and young doctors to be stroke neurologists or stroke physicians. And really, I think we have a legion of people working to help us.
Where do you think we should put the efforts of the aims for developing again the fight against stroke?
Well, now in the World Stroke Organization, I'm creating an international task force, an implementation task force to have people through the world to disseminate knowledge and to help people from different parts of the country, how to implement, how to step by step to build your stroke unit, how to organize stroke care, how to discuss with health managers, because we have a lot of people with experience and also we can help them and schedule virtual meetings with the health managers to trying to convince them of the importance to implement acute stroke care. We are creating in this task force also a strong training, virtual and also in local. We are creating a fellowship for neurointerventionalists in areas without high volumes or where we don't have training in the country. This person can go to another country, be trained, and go back to organize a training in the country to really multiply neurointerventionalists across the globe, because we need much more than we have now. And also, we want to rotate the Global Stroke Alliance, because the Global Stroke Alliance, the idea is to put together everybody that's working in implementation for stroke, researchers, specialists, health managers, industry, patients association, put everyone together, the ideas together, and work in the same direction to improve implementation across the globe. It was very important here in Latin America. The last one month ago, we had 7 ministers of health in person discussing how to implement and how to create national plans. And now the Global Stroke Alliance will rotate through the world to do the same in another regions. The next will be India and Southeast Asia next year, and the idea is to do the same in different parts of the world.
That's great. And do you think that which parts of the world now you think are the less developed in stroke care?
Well, I think it's Africa. We ran a survey through the world in more than 80 countries, 314 hospitals, and we saw that worst developed is Sub-Saharan Africa. They need a lot of help. We are implementing acute stroke care in Ethiopia to show that it's feasible to implement stroke care, acute stroke care in a low-income country. So we start 1 year ago with virtual visit to evaluate the situation, to discuss with directors. We got donation for TPA. We got a free app for telestroke, mobile telestroke from Join app from Japan. And we create a telestroke without borders with specialists from different parts of the world to give advice in real time to Ethiopia to start thrombolysis. They create small and simple stroke units there, and the TPA already arrived, and we are waiting for the first case. We are discussing already with the Minister of Health there if the results were positive, including cost effectiveness study before and after, to really the country start a national plan for the stroke.
A lot to do there. So
yeah.
Did the pandemic of COVID-19 was an opportunity of connecting or maybe virtually, I know, but was there an opportunity there?
Yes, I think we had a lot to work together easily because of the pandemic. And with this, we created the certification program, everything virtual, and we start virtually and we start the on-site visits after pandemic allow us. So really, it was a huge opportunity to connect and to do things as Ethiopian program. Everything was virtual. So really, I think it was an opportunity.
And you mentioned something about the industry. How do you think the industry should collaborate in the stroke development?
Well, I think they are very important. They are helping us a lot. For example, the certification program is free because I believe that the public and private hospitals should participate, and not only because they can pay for the certification. So it's free for the hospitals, and the industry has helped a lot to pay the flight tickets, the visits, the platform for certification. Also, they have a very good equipment for training. So they are very important, helping us in the trainings program too, especially for neurointerventionalists, but not only this. For example, Angels Initiative is a very important initiative from Boehringer Ingelheim that has helped the development and qualification of stroke services across the globe. So really, I think we should work together with them in the same direction to have a better opportunity for development and qualification of stroke services.
Thank you very much, Professor Sheila Martins, for your time. We really appreciate you have talked with us, and we wish you a great presidency for the next years in the World Stroke Organization. I don't know if you want to take a last message for the audience.
Well, thank you for the invitation, Rodrigo. You are already part of our implementation task force, so we need your help, and everybody that wants to join in this very important initiative is welcome. And really, I believe that you can do a lot working together. So thank you very much for the opportunity to talk to you.
Thank you. Have a nice day.
Thank you.